This is a clinical problem that is very common. So it's dealing with patients who are receiving anticoagulants or blood thinners and require their interruption or pausing, if you will. And this occurs in 1 in 6 patients with atrial fibrillation each year, or 6 million people worldwide. And atrial fibrillation is not only the dominant indication for long-term anticoagulation, but it is increasing in prevalence as the population ages. Now, since the DOACs were introduced almost 10 years ago, few studies have looked at how to manage these patients who require an array of procedures, from a dental procedure to major surgery. And the only one study that looked at this only looked at dabigatran or Pradaxa. So it's not surprising there's a lot of variability in clinical practice and inconsistency around guideline recommendations. And the questions that clinicians ask about this problem and the uncertainty is, when do you interrupt the DOAC? When do you resume it? Should you be using perioperative bridging anticoagulation? And do you need to do a blood test to measure the coagulation function before the surgery? And these issues are important because how you deal with them will impact not only on patients' risk of developing thromboembolism and bleeding, but also from a health system standpoint, whether patients need to have their surgery canceled, for example, because there isn't clear evidence about their residual anticoagulant effect. The aim of this study was therefore to establish a safe but standardized and easy to use perioperative DOAC management approach. It was anchored on having DOAC specific interruption, resumption intervals, no perioperative bridging, and no routine coagulation function testing. Secondarily, we also aim to show that over 90% of patients had a minimal to undetectable residual anticoagulant level at the time of surgery. Very important for surgeons and anesthesiologists. We recruited consecutive patients with atrial fibrillation. They were taking one of 3 DOACs, apixaban, dabigatran, or rivaroxaban, required their interruption for an elective surgery. And they were excluded based on standard criteria, in this case, severely impaired renal function. Now, very important part of the protocol was that patients were classified before they had their procedure as being at high risk or low risk for bleeding. And you'll see why in a minute. Just before the surgery, they did have a blood sample, but it was not used for clinical use. It was used later, as you'll see. They had follow-up for 4 weeks and did not receive heparin bridging. This is what the protocol looks like, and it's tailored according to each drug, but really the common denominator is this. For patients having a low bleeding risk procedure, they were off the drug 1 day before, 1 day after. If they had a high bleeding risk procedure, 2 days before and 2 days after. So very standardized, but importantly very simple, because it's something that we wanted an array of healthcare professionals and importantly, patients to understand and be able to adhere to. Here are the results. We screened just over 3,600 patients. There were 17% or so excluded, and we ended up with just over 1,200 in the apixaban cohort, about 670 in the dabigatran cohort, and just under 1,100 in the rivaroxaban cohort. This was done in 23 centers over a 4-year period. This is what the patients look like. This is very typical of a population with atrial fibrillation. They can be categorized by a CHAD score, which provides a risk in terms of stroke and thromboembolism, so they're just over 2.0. And importantly, about 1/3 of all the patients recruited had what would be classified as a high bleeding risk surgery or procedure. And here are the results. So we had expected that the rates of arterial thromboembolism, so this has included stroke, transient ischemic attack, would be around 0.5%. And we wanted to have enough power statistically to exclude a rate of 1.5%. So you can see that this was achieved in the apixaban cohort, the dabigatran cohort, and the rivaroxaban cohort, with rates between 0.16 and 0.60%. And the study was also designed to have a rate of major bleeding of about 1%, but have enough power to exclude a rate of 2%. So we were able to achieve this in the dabigatran cohort, not quite, but almost in the apixaban cohort, and then not quite in the rivaroxaban cohort. Now, the other part that's really of interest, again, to surgeons, anesthesiologists, is what happened to the drugs when at the time of surgery. What was the residual anticoagulant effect? This shows the results according to the type of surgery, whether it was at low risk or high risk. So not surprisingly, those at high risk, a higher proportion of them would have minimal to no detectable anticoagulant effect. Overall, about 99% had a level less than 50 nanograms per ml that we thought would be clinically safe threshold to allow a surgery to proceed. If you wanted to look at it even more critically, and the levels, the proportion of patients who had undetectable levels by the assays, these were about 93% in the apixaban high-risk cohort, 99%, and a little bit lower in the rivaroxaban cohort. So the interpretation of these results would be that in patients with atrial fibrillation who are receiving a DOAC and needed it to be interrupted for an elective surgery procedure, the pause protocol strategy, which we felt was standardized, forgoes bridging, heparin bridging, and forgoes preoperative anticoagulation testing, was associated with low rates of major bleeding, less than 2%, and arterial thromboembolism, less than 1%. The management was also associated with a high proportion, over 90% overall, 99% in those at high bleeding risk, having a minimal to no residual anticoagulant level. And overall, this is the first study to demonstrate the safety of a standardized perioperative management approach in patients with atrial fibrillation who are taking a DOAC, and we hope will establish a standard and will have an effect on clinical practice guidelines. And I will finish by just acknowledging our funding support.